We have some patients that often ask us, how long will my lens last? Won't you ever have to do anything else to that lens? And what I usually tell them is the lens may last, but there might be other issues that may force us to do something with that lens that was implanted at the time of cataract surgery.
Yeah, the actual material itself is made to last for a lifetime, but the challenge is the location, the placement of that lens. Sometimes it's compromised by the patient's anatomy. Where that lens is placed is usually in the capsule, and that can start to dislocate from these string-like fibers, these zonules that hold it in place. And this is an interesting case of a patient who had a dislocated lens in clinic. Then we're going to see the time when they get to the operating room, and it's about gone. It's about completely dislocated at that point.
I still remember in clinic, I asked her, do you notice anything? She's like, oh yeah, I see it. I can look through it, but there's a little part that is out of focus. She could still see it. I could see it. This lamp. And going back to the zonules, I usually compare them to the spokes on a wheel that keep the hub in place. And if they're broken, the hub falls, which is the lens. But by the time we're in the operating room, there's nothing there. It's just an open pupil looking straight at vitreous.
This looks like a
mid-dilated pupil. And what I do initially is place viscoelastic. After that, I came with epinephrine. Mid-dilated pupil, but makes it a little bit more difficult. Now I'm just looking for the lens.
Where is it?
Where is the lens?
And we're getting the view. So the bottom of the screen is the superior part of the cornea, the top of the eye.
Inferior part. So bottom is the superior part. You're correct. Yes, you're absolutely correct.
But I get it confused all the time.
Correct.
The bottom of our view is the superior part of the cornea.
Yes.
The top of our view, so everything's flipped is what we're getting at.
Correct.
This is filling up the anterior chamber with viscoelastic, still not finding that lens. And now you're going through the sclera.
And you might have seen a little bob early on where the lens was. This is a trocar that's placed into the sclera underneath conjunctiva to do a vitrectomy, remove the vitreous, and there's the lens. Comes into view as the trocar pushes from behind.
This seems a little dicey to me because now it doesn't seem like it would take much for that lens to fully move even further back into the eye.
Correct. I am not particularly comfortable at this point, but I fortunately am able to push the lens, since I know where it is, into the front and able to hold it and grasp it with a little forceps.
Now, I think some things can predispose patients to having this happen. Patients who have pseudoexfoliation, where they have a flaky white type of material that deposits around the lens, that can make the zonules very weak. Other systemic conditions like Marfan syndrome, for example, even trauma could make this much more likely to have a dislocation.
Correct.
Do we recall why this patient had a loose lens?
I don't remember, but the other important didn't happen here, but surgery, vitrectomy, also caused weakening to the zonules, because as you try to remove as much of the vitreous as possible, the vitreous base and the zonules coincide. So when you, quote, shave the base, you tend to weaken the zonules, so that can also sometimes lead to dislocations later, not at the time of surgery, but later.
Now, you're probably feeling a little better because the lens is starting to get into the anterior chamber here, so getting a firm grip on that.
But you can see by how decentered it is that I was trying to work as efficiently as I can. Here I'm cutting the lens in two and removing it from the eye, but partially separating it, holding it so that it gets in two pieces and gets torqued out of the wound, kind of turned out slowly.
Now I look at the situation and say, well, this is a predicament because now we have an eye that's coming out and there's not going to be a place to traditionally put that new lens. So this is where a scleral fixated lens technique is going to come into play to actually get a lens behind the iris, but still be fixated to the back of the sclera.
And that little dust that you saw coming in, snow, should show up any vitreous. So it kind of should collapse. I didn't see any. Here I'm marking a little excessive, 180 degrees apart, 3 millimeters posterior to the limbus, the border of the cornea, to the iris, and then 3 millimeters on each side. So 3 millimeters is pretty far back. Reason is I don't want that lens to rub against the iris. We've seen plenty of UGG, uveitis, glaucoma, hyphema syndromes. Here, the leading sutures are placed in a B cartridge, which is the cartridge where usually an IOL is implanted. A larger intraocular lens. This is a one-piece. Traditionally, one piece shouldn't be placed in the sulcus. This, again, is far back. We'll show later where exactly it's placed, so lower risk of interacting with the two.
The question I have about that placement of the lens, does that require a change to the lens power calculation because you know it's going to be a little more posterior, a little further back in the eye?
So I tend to aim for a -1, which makes them pretty close to no prescription. However, you just see what I'm doing. I'm measuring, I'm doing millimeters on a caliper. These are not very predictable in my hands cases, so I just want to make them better. If I can get them into glasses that work, I'm very happy.
It looks like literally threading a needle, but while you're inside of the patient's eye.
Very nice.
Is that prolene, that blue prolene
Yes.
type of tissue?
It's a 6-prolene which is pretty stiff, but still pliable enough so I can move it and get it into the needle. And then I basically thread it far enough so by the time I pull out the needle, it's already through the sclera. So think of it like feeding it through the sclera while I'm pulling, and then as it comes out, you can see the needle almost removes itself around the suture.
Maybe this is an overly simplistic analogy, but I think of creating almost like a hammock behind the iris, and you're getting two prolene going through one side, two prolene through the other side, and it's going to hold that in place.
Correct. And here important that the torque, so the two loops pass, and they have an orientation, right? Because the loop, if it goes front to back, is perfect. But if it goes side to side, it can induce some torque. So they should be exactly counter torque. So one rotates to the right, the other one rotates to the left. Thus, they even each other out and keep it flat.
Now, this type of lens implant has the actual haptics that has a hole, an opening where you can pass that through. Yep. Is that why this lens is chosen, or could you do the same technique with other lenses and create your own perforation through it, or how does that look?
There are certain tools, punches, that you can place it through. What I'm concerned about is, like, I don't know how precise it is. This lens was not intended for the use that I'm using it for. It just happens to have that opening, and it centers, as you can see, very nice. The other traditional lenses, some have eyelets, sometimes it's looped around. There's whole books written on scleral fixation. This is called a quote riveting technique because you create this little bulb at the end that then will prevent the suture from sliding into the eye. And you can do this even if you have a lot of, like in this case, conjunctival scarring. So what I like is, I remember this patient actually had retinal surgery, so you see all this scarring. The conjunctiva is not very loose at all. So that's probably the reason why the lens dislocated. But that makes any scleral fixation more difficult because usually you have to remove the conjunctiva, do your sutures, and put the conjunctiva back, which is difficult if it's scarred. This little knob slips underneath the conjunctiva heals over it. So it's more forgiving in these kinds of cases. And as you said, all I do is create this little bulb that prevents it from slipping in. The suture is thick enough. This is probably the equivalent of a haptic. Sometimes you'll hear about the Yamane technique. We can link a video to that where this haptics are externalized. But the problem is if you have a large eye, the haptics might be too short and they're not made for that length, so under stress. And you can't place it as far behind the iris. Here I can go however far back I want because I have inches of suture that will support the lens no matter where it is. You saw how long that suture was. I mean, it could pass several times across the eye. And so I tend to now appreciate this technique, and I've done it several times. It took me a while to get to this, but it's predictable, safe. I like to have the difficult part, as you saw, outside the eye. So inside the eye, if something goes wrong, I have plenty of ways to recover, as opposed to with others where inside the eye goes wrong, I have to refer to my retinal colleagues.
One other interesting point about this case was those little blue parts that become a little bit bulbous and stick in the sclera. You actually see those for the rest of their life. Yes. You look at a post-op and I can see those small little 4 blue dots that indicate where that's been pressed into the sclera, and it doesn't cause any problems and it just stays there forever that way.
And the head is like a little mushroom. So the reason I like this technique is because it's placed directly into the sclera and then it's a smooth surface. So if it's a little bit elevated, it's a very nice smooth surface that the conjunctiva covers. And some of the other techniques, the haptic enters at an angle and through a tunnel, so it can erode either way. This one goes straight in, so the only tendency is to go deeper, which should lead to less irritation. But as with all these early, so we'll see what in the long term these are. The other sutures as a comparison that we used to use is 10-0 prolene or 10-0 nylon, which is way thinner than 6-0.
Got it.